Okay, so we're going to continue on. We're going to start with lecture 14, and then I'm going to try to get through 15 as well, but we'll see what we can get through today. I know I have a lot of material to get through, and yep. So depending on how quickly things are going to go over the next few days, I may have to skip the workshop section on the last one and just continue doing the review and all that. So we'll kind of play it by ear and see how much we can get through. But the first thing we'll do today is going to be the study of causation in epidemiologic investigation and research. So some of the things we're going to do include talk about different types of causal relationships. Don't get dyslexia like me and read that as casual very frequently. And then we'll understand some of the steps involved in determining both cause and effect, right? Because we always know that correlation does not equal causation, but we can find some of the ways that we can investigate that to determine what is a cause to an effect that we're seeing. So we're also going to review some of the common pitfalls when we're looking at causal relationships in research, including things like bias and random error. So we'll discuss those in more detail. So frequently you're going to see the epidemiologists are going to be involved in studies that try to determine causation. They're trying to figure out the specific cause or causes that lead to a disease or an outcome that they're investigating. This is oftentimes pretty difficult and pretty elusive of a task to accomplish, because we always know there's so many other factors that are involved that go into any sort of health issue. And so, for example, a newspaper article that was looking at cigarette smoking, they had a spokesperson from the Tobacco Institute, that was a trade association from the cigarette manufacturers. He's actually saying that he did not deny that smoking was a risk factor, though not a cause, for a variety of diseases. So we can look into that claim to determine, is that factually accurate what he was saying? Is it, is a risk factor a cause or is it not? Let's look into that a little bit more in detail. So we'll look at the types of causal relationships. Specifically, we'll look at sufficient cause, necessary cause, and then we'll look at risk factors as well. This is kind of a brief overview, so you can kind of refer back to this to get a summary of the different things we'll talk about when looking at causal relationships. I'll go into more into details in the following slides. So the first thing we'll look at is going to be sufficient cause. So this is going to be something that precedes a disease and has the following relationship. So basically, if the cause is present, the disease will always occur. So an example of this, they're pretty rare for the most part, but you can see this oftentimes with like homozygous genetic issues, especially with things like fatal diseases like Tay-Sachs, other types of genetic causes where if you're homozygous, you have both of those genes, you're going to have the condition no matter what. So that's going to be a sufficient cause, right? So if you have the cause, you're going to have the disease the effect. So do you think smoking is one of those?
No.
Why not? Right, so just because I smoke, does that mean I'm always going to get lung cancer?
No.
Not necessarily. What if I get hit by a car the next day after I start smoking? Maybe if I lived long enough, who knows? But in that instance, we'll see that smoking will not be a sufficient cause for lung cancer specifically. So, like we said, there may be people who smoke who do not acquire lung cancer before they die. I say something else. And it's unknown whether all smokers would get lung cancer if they lived long enough or they smoked long enough, right? And so with the human lifespan, smoking cannot be considered a sufficient cause of lung cancer, right? Okay, so if it's not a sufficient cause, then what other types of causes can we look at? So something that would be more frequent would be necessary causes. So this would be something that precedes a disease and has the following relationship. The cause must be present for the disease to occur, although the necessary cause may be present without the disease occurring. Okay, so a good example of this would be Mycobacterium tuberculosis, right? So I can have a latent infection of tuberculosis, but does that mean I have active disease? Not necessarily, right? So I can test positive for PPD, or tuberculin skin test. That is not just because I'm positive for that does not mean I actually have active disease in that circumstance. Can you guys think of any other things that might be necessary causes?
Strep laryngitis.
Okay.
Kind of mycobacterial.
Okay, so maybe like how about something like, I'm trying to think of another good example of that. Possibly. Any other examples you can think of? They're kind of hard to conceptualize, but if you think about things like, for instance, having, definitely hard to come up with some certain, I know, right? hard to come up with an example specifically.
specifically.
Yeah, acute rheumatic fever, right? So strep pharyngitis may be one of those necessary causes where you can have strep pharyngitis, does not necessarily mean you're going to have acute rheumatic fever, right? So that may be one example of it. But basically, these are things that are just prerequisites to having the disease, but does not cause it itself, right?
Cause it.
I'm sorry?
So it doesn't cause it.
It is a cause of it, but it doesn't necessarily mean that you're going to have the disease. So just because I get infected with tuberculosis does not mean I'm going to manifest symptoms of the disease, right? I can have the latent infection, but it never activate for me, right? Similarly, you may have someone who has HIV, they may never manifest AIDS, depending on what their situation might be if they die from something else. But they're never going to develop AIDS unless they have HIV first, right? So that would be another necessary cause. So cigarette smoking in this case would not be considered a necessary cause of bronchogenic lung cancer because we know that lung cancer can and often is caused by other things, right? So we can see that exposure to lots of environmental toxins, things, especially occupational exposures, exposures to things like radiation or arsenic, asbestos, all these things can also cause lung cancer. So in this case, smoking would not be a necessary cause because there are other things that could lead to that, right? So this one would not be a necessary cause for lung cancer. Now, certainly other things that can fall into this kind of a much more broad category of risk factors. Risk factors are going to be exposures or behaviors or an attribute that if it's present and active, it would clearly increase the probability of a particular disease in a group of people who have that risk factor. So in this case, do you think smoking is a risk factor for lung cancer? Absolutely, right? Because we've seen data that says that people who are having the behavior of smoking, they're going to be more likely to develop lung cancer than the people who do not have that risk factor, right? How do you think we determine that sort of relationship? So we do studies, and then we do what?
Correlation coefficient.
Okay, so we can look at correlation coefficients. We can start to do things like, say we're looking at two different samples, one that smokes and one that doesn't smoke. We could potentially do like a t-test on them or something to see, what was the incidence of lung cancer in one group versus the other. So you need to achieve statistical significance when looking for differences between these groups that identify some of these risk factors. We'll look at more of that in detail in just a minute. For example here, although smoking is one of the most important risk factors, producing 20 times as high risk as lung cancer in men who are heavy smokers, it's neither going to be a sufficient cause or a necessary cause for lung cancer, right? So in this case, it's just going to be a risk factor. So in this case, when you're looking back at that quote that the guy from the tobacco manufacturer said, it says, that he did not deny that smoking was a risk factor, but it's not a cause for a variety of diseases. Strictly speaking, he was probably correct, right? So it's not necessarily a cause, but certainly it's going to be a risk factor. And so what he was saying was kind of just half-truths, right? Which is what a lot of statisticians will do and a lot of research out there. So this is why you got to be really careful and kind of look through some of this stuff. So we know, though, that smoking is going to be one of the most important risk factors in this case and going to be one of the big things we can do to help prevent lung disease or lung cancer specifically. So we can also look at causal and non-causal associations. So the requirement for a causal relationship to exist is there has to be an association between the outcome of interest and the presumed cause, right? So in this case, do you think smoking had a causal relationship with lung cancer? I would probably say so, right? So we know that there's going to be an association. We'll talk more about that in a little bit. But essentially, the outcome must occur either significantly more often or significantly less often in individuals who are exposed to the presumed cause than in individuals who are not. And so we can look at things that are either a risk for something occurring or it could be a protective factor that we'll look at. So we'll kind of look at the differences there. Basically, just exposure to whatever behavior, whatever happens to be, should have a statistically significant effect on that group and the outcome of whatever you're looking at. So some difference would be expected just to occur as random variation, but by doing these statistical tests and showing a true difference between the groups, that's where we're able to develop these causal relationships between one another. So again, we have to show that there's a very small chance that the differences we're seeing are just due to random variation alone, right? So that's why we're looking for big or small p-values. You want small p-values, right? You want something less than 0.05, saying you have a very small risk that this is just due to chance alone. So if an association is causal, the causal pathway may either be direct or going to be indirect. And so we're going to see that this can vary based on kind of what you're looking at, but the classification is going to be depending on the absence or presence of these intermediary factors. And another name for this are going to be intervening variables. So a good example of a direct causal association in this case would be something like a severe blow to the head leading to brain damage, right? So you say what caused the brain damage, you're going to say the blow to the head, right? So there's no kind of intervening variables in between there during that circumstance, right? So it'd be a direct causal relationship. Now, on the other hand, you can have indirect causal relationships, which are going to be things that have some sort of intervening variable between the effect or the cause and the effect happening here. So, for instance, if you're looking at something like poverty itself may not directly increase, disease and death, but you can also see that poverty has indirect or intervening variables in between there, things like adequate nutrition, housing, medical care, that can lead people to be more at risk for developing disease and death, right? Also looking at things like, say obesity and heart disease. There may be some other intervening factors there, things like high blood pressure or things like atherosclerosis and high blood cholesterol and things like that. Those would be intervening variables between the obesity and the actual cardiovascular death. So again, when looking at this, a statistical association may be strong and may not be causal. So in this case, you could have a non-causal association. So something that appears to be truly different. There appears to be some sort of statistical significance, but there may not actually be a true cause here. And so an important principle, as we already kind of mentioned here, is that the association does not prove the causation. We'll look at some other factors that are involved with that. But again, if a statistically significant association is found between two variables, but the presumed cause occurs after the effect, then of course the association is not going to be causal. So again, we're going to look at temporal relationships and how that's going to be important in establishing cause and effect. We'll kind of equate this to like a murder investigation, as you'll see in a couple slides. But essentially, you need to make sure that the cause is happening before the effect occurs, right? Otherwise, you can't really establish that cause and effect relationship. So a good example of this in a non-causal association would be estrogen treatments for postmenopausal women were being associated with endometrial cancer and were considered by many to be a cause of the cancer. Okay, and so after a while, it was then realized that the estrogens that were being given oftentimes were being given to control early symptoms of undiagnosed endometrial cancer, such as bleeding, right? So in some of these women, they were having the effects of the cancer before they ever received the estrogens. And so in that case, would the estrogens be a cause of the cancer? Right, they've never been exposed to it. So again, having the timing down is going to be really important for these things, and why we'll look at some of the shortcomings of some of the study designs that we can run that may lead us to not really be able to establish this kind of cause and effect relationship. But so again, sometimes estrogens are being prescribed long before the symptoms of the endometrial cancer, in which case there is evidence that estrogens may contribute to the endometrial cancer, but you have to establish that relationship first, right? You need to be able to detect the disease occurring after the actual cause has been initiated. So if a statistically significant association is going to be found between two variables, but some other factor causes the presumed cause and effect, then that association would also not be causal, right? So one, you have to prove a temporal relationship between the two. But here we also need to be able to say that, okay, there's probably not any other kind of intervening factors. You need to have some kind of biological plausibility here that would make sense. So in the case, we can look at something like baldness may be associated with the risk of coronary artery disease, but we know probably that baldness is not likely to be a cause of coronary artery disease, right? Biologically, that doesn't make a whole lot of sense. However, on the other hand, you can look at some other kind of intervening factor here with something like the levels of dihydrotestosterone, or DHT, which is a potent androgen that testosterone gets converted into. And so if you were to look at levels of DHT, you would see that that would have a causal relationship with both baldness and coronary artery disease, right? So you need to make sure there's not some other kind of relationship that you're not really taking into account. So how do we determine cause and effect? We're going to go through some of the steps here. So first off, you need the investigation of a statistical association. So investigators may be able to test hypotheses about risk factors or protective factors. You need to kind of have an idea of what you think may be either putting someone at risk or maybe a protective factor here. So for example, for causation to be identified, the presumed risk factor must be present and significantly more often in people who have the particular disease of interest than those without, right? So you need to be able to show that statistical significance, that difference between the two groups, to say that those that have the risk factor are more likely to have the outcome. And so that difference must be large enough to really be considered statistically significant to eliminate the chance differences. So again, achieving that p-value of say less than 0.05 to show that the observations you're making, that difference between the groups, is truly due to a difference and not really just due to random sampling. And then on the flip side, if you're looking at, say, a preventative factor, something like a vaccine, again, you'd have to have that being present significantly less often in individuals with the disease than those without it. So again, just keep in mind that the protective factors are just the flip of a risk factor. So when the presumed factor, whether it be a risk or whether it be a protective factor, is not associated with a statistically different frequency of disease, then that factor cannot be considered causal, right? So if you were to run a test between two different samples, one who had the risk factor and one who didn't, and you found no statistical significance there, then you cannot consider that to be a causal relationship. You could have something else that's really obscuring the real association between the factor and the disease. Maybe you have some kind of confounder that's affecting this, or some sort of bias in your research design. And so by having proper research design and having the proper statistical tests, you may have shown a real association there, right? So sometimes if you were to say there was a true difference between samples, but you couldn't detect it, what could that be a problem with? What type of error would that be, first off? Yeah, it'd be a type 2 type of error, right? Because there is a difference, but we couldn't detect it. And so what could be affecting that? What could cause a type 2 error like that?
Sample size?
Yeah, so maybe I didn't have a big enough sample size to show a true difference between the groups. You can also see if you were not really controlling for certain confounders, that could also be kind of obscuring your data and not showing a difference when one truly exists there. So there's going to be lots of different factors we're going to look at in order to help control for these differences to make sure we can find a difference when one really exists. So the first step in an epidemiologic study is to show the statistical association between the presumed risk or the protective factor and the occurrence of that disease. And so the equivalent to, say, our murder investigation here would be to show that there is a geographic and a temporal association between, say, the accused murderer and the victim, right? So you need to show that both were in the same place at the same time, or that the murderer was in a place from which he or she could have caused the murder, right? So you need to be able to establish that relationship beforehand, and that's synonymous with doing our statistical test to show that there really is a true difference between people who had the risk factor or the protective factor in the occurrence of that disease. So the relationship between smoking and lung cancer provides a really good example of how an association can lead to further understanding of causation. So in early studies showed that smokers had an average overall death rate approximately 2 times that of non-smokers. And so the studies also indicated that the death rate of lung cancer amongst all smokers was approximately 10 times that of non-smokers. So these studies, because they were able to show such a large effect and show that this was not just due to random sampling, was allowing us to identify the role of cigarettes at least being a risk factor for lung cancer and then lots of other diseases that we've kind of uncovered through looking at these causal relationships. So the research design must allow a statistical association to be shown if it truly exists. So again, we're going to do this either by comparing the rate of disease before or after an intervention. So in some cases you can take, say, a group of just one sample of people, and you can do kind of a pre-post test on them to determine the effectiveness of an intervention. So say you were looking at occurrence of flu in a population, and you were taking a random sample of that, and you were saying what was the flu rate before we gave you a vaccine, and then what was the flu rate afterwards, right? Because that's something that could reoccur multiple times. That could be one example. That, or you could compare groups with and without the exposure or the treatment. So if you were to take two, say do a randomized controlled trial, take 2 different groups, and say give one the intervention and one a placebo, that would be the other way that you could show this statistical significance. And so the analysis is needed to show that the difference associated with the intervention or the exposure is greater than would be expected by chance alone. And then we have to estimate how large of a difference that really is. And so that's what we're really doing with these statistical tests. So if a statistically significant difference in risk of the disease is seen, then you have to consider the following. So again, did the therapy make the patients better or worse on average? Was the difference large enough to be etiologically or clinically important, right? So that's going to be a little bit more of a subjective kind of determination, right? So if we see small changes in the samples that we're looking at, is that going to be clinically relevant to us or clinically important? And then even if the difference observed is real and large, even then, your statistical association still does not prove causation, right? Because there still could be some other confounding factor we're not taking into account. There could be something else that's going on there. And so even though it may seem initially that an association is causal, when in fact it very well may not be. So for instance, there's an example where, say in the era before antibiotics were being developed, we were treating syphilis with arsenic-based compounds. Even though arsenic is pretty toxic. Does anyone know where we use arsenic clinically nowadays?
Hypertension.
No, you wouldn't want to give someone arsenic with hypertension. What could we treat someone, what kind of disease state can we treat with arsenic-based compounds? Yeah, basically just cancers, right? Really the only big thing. We didn't really cover it in the hemonc section, but that's one of the few places, right? Because we know it's very, very poisonous. But back in the day, before we had a lot of good antibiotics, we used it to treat syphilis. So in this case, when we were in this kind of environment, we were having an outbreak of fever and jaundice was occurring, and many of the patients were being treated with arsenic. And so at the time, it seemed pretty obvious to everyone that, okay, well, these people are getting really sick, or having hepatic injury, things like that. It must be due to the arsenic. When in fact, when they were actually looking at it afterwards, hindsight's always 20/20, they were finding out that this is probably likely due to another type of infectious agent. So due to the fact that the needles that they were using, they'd have to sterilize and reuse, there were some issues with the sterilization process they were using and actually spreading hepatitis B or C amongst users, right? So even though it seemed obvious that this was, the arsenic was the smoking gun here, it actually was probably due to something else that they were not able to identify at the time. So there are several criteria that, if met, increase the probability that a statistical test is going to be causal. So we'll show you some of these in just a minute. These were developed from John Stuart Mill, often known as Mill's canons. So these are the factors that if you see these happening, there's more likely to be a true a causal relationship that you're showing between your whatever your risk factor is and your outcome. So we'll talk about some of these in more detail, but some of these we've already covered. So one, the following factors increase the likelihood that it's, the strength of the association. So the bigger the differences between the groups, the more likely are to see a true causal relationship, right? That makes pretty good sense, because we know also that the bigger the effect is between the groups, the easier that is to determine statistical significance, right? So it's a very small difference between groups. It's more difficult to find that true difference there, if there is one. But if it's a very large difference between groups, statistical tests can find that difference more easily, right? Remember that? Effect size is going to be important there. We're going to see that the consistency of the association. So if you were to repeat the test several times and say different random samples, you would always find the same results. That's also going to be another thing that kind of strengthens that causal relationship. We'll look at the specificity of the association, meaning that no association is found if the causal factor is not present, right? So if it's absent, you would not see that relationship there. And then the biological plausibility of the association, so making sure that it makes sense from a biological standpoint. And then also that there is a presence of a dose-response relationship. So that the greater the presence of the causal factor, the greater the effect you're going to see there. So in the instance when we're talking about something like, say, smoking, we can definitely see a dose-response relationship here, where if you were looking at the number of deaths you were having based on the number of cigarettes smoked per day, you can see here in this graph that 7 deaths occurred in men who did not smoke at all, 47 in those that were smoking about a half pack of cigarettes a day, and you see that it steadily increases. So that the more patients are smoking per day, the more likely they are to die from that. Conversely, the less they're smoking, the less likely they are to die. So again, showing that dose-response relationship is going to be another thing that leads you to think that yes, this is truly a causal relationship that we're looking at here. So, and again, assuming that time only runs in one direction and is linear, unless you're watching something like Westworld. I won't get into too many spoilers there. So to show causation, the suspected causal factor must have occurred or been present before the actual effect happened, right? So this is that temporal relationship that we're talking about. And so proving that relationship can be very difficult depending on your type of study design that you're doing. So you need to have some sort of experimental control that's available. And so one of the ways we can do this is using something like randomization of our samples, right? So if we can randomize a sample followed by measurements of the risk factors and then disease in both groups before and after our intervention, that's much easier to determine a causal relationship based on a temporal, say A follows to B follows to C, than it would be if we were looking at data retrospectively. So it's always easier to do this prospectively. So for instance, with chronic diseases, the onset of the effect is going to be pretty unclear in a lot of situations. So, for instance, someone who has a heart attack, when did the atherosclerosis begin? That's going to be pretty difficult to say, right? When did the first bronchial cell become cancerous? These are questions that you're never really going to have good answers to. And then the onset of the risk factor may also be unclear. So, when did the blood pressure begin to increase? When did the diet first become unhealthy for that patient? Some people may have started very early, some people may have started very late, and they could have different outcomes based on that. So, figuring out that kind of cause and effect can be difficult if you can't really figure out the time relationship between the two. So, because of the long but varying latent periods between onset of risk factors and the onset of diseases, the relationships are going to be obscured. Very frequently, you'll see that there's kind of a vicious cycle that can happen with a lot of disease states. So, for instance, chronic disease such as obesity can cause osteoarthritis, which leads to more inactivity, which worsens the obesity, and vice versa. So you can see there that establishing those relationships can be very difficult. And so, research design is going to be really important in helping us to determine these temporal sequences. So if information on cause and effect is to be obtained simultaneously, so say for instance you're doing a survey, I just did a survey of all you guys in the class, it's going to be difficult to decide whether presumed cause or the effect first began. So for instance, basic demographic variables such as gender and race would have begun, right at birth or before birth, obviously, but those are going to have an effect before diseases caused by, external risk factors really begin. So those things are pretty easy to determine, but very frequently it's impossible in a survey or in a single medical visit to determine which variables really occurred first. So in evaluating temporal relationships, parallels can be drawn between epidemiologic investigations and, say, murder investigations. So in this instance, say, who's often, someone who first walks up onto a dead body. So say you're in a Law and Order episode and you're the jogger going through the park and you're the first person on scene when you find that. One of the things you have to consider is well, that person was, temporarily there with the murder victim, but are they the killer? They could be, right? But how do you determine that? So it's on the lawyer at that point to determine that, okay, well, this person had an alibi. They'd been, cited somewhere else, 10 minutes beforehand. So they couldn't have possibly murdered this body that was been there for 2 days, right? So things like that. So trying to establish that temporal relationship can be very difficult, but that's one of the burdens of doing these kind of epidemiologic investigations. Basically, just don't go running through Central Park and you never find a dead body and you're good. So another good example of this temporal relationship would be looking at prenatal care evaluation. And so looking at fetal outcomes based on the amount of prenatal care that the mother got beforehand. So essentially here, one of the things that they kind of took for granted was that patients who had more prenatal care or say more prenatal visits with the provider ended up having positive effects on the health of the infant, so either in birth weight or survival. So even when they were looking at the socioeconomic status and the education, when you control for those factors, they still found that more prenatal visits led to better infant outcomes. So can you guys foresee any problems with that?
There's a point of diminishing returns, right?
There could be a point of diminishing returns. So let's look at one of the. So they were saying, okay, well, obviously if you go to visit your provider more, you're going to have better fetal outcomes. But let's go ahead and look a little bit deeper. What if you're more sick? So that should be one thing you should be encountering, right? So that'd be one of the things you want to look at to say, okay, well, who are the mothers who are at biggest risk for having a bad fetal outcome? Maybe they were getting more visits. Yeah, so that'd be one thing you'd want to control for in a research design to make sure that the health of the mother isn't impacting that. This is why they also looked at the socioeconomic status and things like that. But there's another factor that they did not take into account. And so in this case, if you're looking at how visits are predominantly done, you'd see that the longer the pregnancy is going on for, the more visits or the more frequent the visits become. So say for instance, you're doing biweekly visits after week 28 and then weekly for the last 4 weeks. So if you carry a baby for longer, you're more likely to have more or less visits. More visits, right? So those are probably going to be healthier or sicker babies. probably healthier, right? So obviously a baby born at, say, 42 weeks is going to do better than one that's born at, say, 28 weeks, right? So because those women who are already going to be predisposed to having a healthy baby, they're holding the baby for longer, so they're getting more visits in. And so that could have been kind of a false association they were making there. And so when they were actually looking at that and they took that into account, the studies, when they control for that, they were able to find that, better prenatal care does provide some benefit, but it probably wasn't as strong as what they would have determined just based on the pure number of visits that they were looking at before. Right. So again, taking those confounders into effect to make sure that we're looking at these relationships appropriately. So again, looking here at just another kind of a graphical representation of it. So again, having a preterm delivery, what was that association between the reduced number of prenatal visits and low birth weight infants? Obviously, those women who are going to have a healthy infant probably had more visits because they were carrying them for longer. So less preterm births in that group anyway. So another thing you have to do is kind of to rule out all the alternative explanations. So say in the murder case example, the verdict of not guilty, meaning we have to prove it beyond a reasonable doubt. Usually it can be obtained for the accused person if that person's attorney can show that there is another possible scenario, another probable cause of what truly happened in that example. And so, evidence of that person, say, was at the scene of the crime, and say someone else was there who had a pre-existing murder conviction or something like that, some other kind of smoking gun, has to really be ruled out before you can say, yes, this is a true causal relationship. So in the case of an epidemiologic investigation concerning the causation of a disease, even if the presumed causal factor is associated statistically with the disease and occurs before the disease appears, it's necessary to show that there's no other likely explanations for the association. So by looking at proper research design, this can reduce the likelihood of competing causal explanations, especially if you can control for that by saying matching up your groups appropriately or being able to control for different factors there. And then also if we're doing randomization appropriately, ensures that neither self-selection bias nor investigator bias is influencing the allocation of patients, which may affect your results, right? So we'll talk about some of those biases and some of those issues that can pop up when we don't perform randomization appropriately. And so efforts have to be made by the investigator to reduce these measurement biases and other potential problems. So looking at things like differences between the number of subject loss to follow-up and things like that. So really the investigator, the onus is on them to make sure that they are trying to account for all these possibilities to rule out other causal relationships, to show that the true difference that they're seeing is really due to that and that alone. So the criterion that all alternative explanations be eliminated can never really be fully met, right? There could always be some other explanation for something that we see that we don't determine for several years after the road, right? There are examples where we thought that before we started washing our hands to help reduce spread of infection before we knew about germs, right? So again, one of those things that would get challenged as science gets better, as we start to determine things with more better accuracy there. So for example, when we're looking at the classic theory on the origin of peptic ulcers, they thought stress and hypersecretion. It wasn't until it was challenged by one individual who was willing to drink, H. pylori to really be able to determine that, yes, this is one of the big causal relationships. I can see this as well. And so these explanations are always going to be tentative. Nothing can ever be 100% certain. You really just have to go with the research and the statistics that you have at your disposal. So another good example of this would be looking at, say, alternative explanations for coronary heart disease. And so looking at, in the past, before we had a lot of good explanations for this stuff, several studies looking at atherosclerosis and myocardial infarction, they were basically questioning the adequacy of the current paradigm at the time, that hyperlipidemia, hypertension, and smoking as the main causes of CHD. And so some of the things they were looking at, especially to the hyperlipidemia theory, where they were looking at excess levels of iron in the body that was causing these atheromas to develop by oxidizing cholesterol. And the fact that when the statins came about, things like simvastatin and atorvastatin came about, and they were able to show that they reduced the number of negative cardiac effects or events that they basically were able to kind of rule out that iron-based hypothesis, right? They were able to show that, okay, well, when we actually dealt with the cholesterol, we were able to reduce the number of effects that we're seeing there. So maybe the iron is not really such an important factor here, right? So again, we're always going to find new alternative kind of reasonings for things. If you remember the old hyperlipidemia guidelines, they were really focusing on getting your LDL down to a certain number, looking at HDL, and nowadays, what are we treating based on? Well, like cardiac risk factors, right? So looking at things like, do they have diabetes? Do they have hypertension? Have they had, previous cardiovascular disease? We realize that, the effects of statins are really not so important on the numbers, but necessarily, what are the risk factors for the patient? So you're going to see things change like that over time as the science gets a little bit better, as we do more studies. We know that in all probability, lots of factors are going to contribute to the end result of atherosclerosis, and that we know that many hypotheses can be complementary, not necessarily competing. So sometimes you'll see kind of groups of theories that kind of come together to provide kind of a better picture. So say, for instance, you're looking at newer hypotheses, looking at the role of chronic inflammation in developing coronary atheromas. Some of the things they were looking at including chronic inflammation leading to endothelial damage with the thrombi that are forming in the vessel walls, looking at hypercoagulability and things like that, and then also looking at these chronic infections that can produce plaque instability. If a plaque then breaks off, it can cause thrombi and causing an MI. And so one of the things that we're looking at was looking at treating some of these infections, especially if they're looking at patients who were having increased risk of cardiovascular disease, especially if they had gram-negative bacteria like chlamydia, pneumonia, H. pylori, things like that. They were looking to see that if maybe we treated those infections, maybe you can decrease the inflammation, decrease the chance of having a cardiovascular event later on down the road. So some of the things they were looking at there was they were looking at antibiotic treatment for chlamydia specifically, and they showed that using this macrolide derivative ended up reducing the number of cardiac events that were there, right? And so that not all studies have been able to replicate this and show that antibiotic treatment reduces the number of cardiac events. But again, it could be one of those things that you're going to see more research down the road that may prove this to be a more commonly held assumption that we would treat based on. So again, medicine's always going to be in flux. The things that you think are totally true nowadays are probably going to be proved wrong 10 years from now, and just you have to roll with it. Medicine's pretty great for that for the most part. Okay, so what are some of the common pitfalls that we're going to run into when looking at causal research? So bias is going to be a big one. So bias is also known as differential errors, and can be a big source of error in epidemiologic research. And so these can produce deviations or distortions that tend to go in one particular direction. So this can either weaken a true association, meaning that you're more likely to make what type of error? Yeah, it would be a type 2 error, right? So you cannot see a true difference when there was one present. Produces a spurious association, which would be a type 1 error, right? So a seen association is not really truly there. Or it can distort the apparent direction of association between variables. So instead of making it look like it goes one direction, it could go the other one. There are lots of sources of bias. Can you guys think of any sources of bias right off the top of your head? That's okay, we're going to go over lots of them, but just realize there are too many to list, but we'll look at some of the big ones. And some of the big ones we're going to see include things like assembly bias and also detection bias. So assembly bias is going to be occurring during the initial kind of generation of the trial. So the first step in a clinical trial involves assembling the group of subjects to be studied, right? So how do we collect that group, and how can we introduce bias in this in that setting? So if the characteristics of the intervention group and those of the control group are not comparable at the start, the differences and the outcomes can certainly be seen. So this can be due to might be due to assembly bias instead of being due to the intervention itself, right? So if you see a true difference between groups, were the groups truly equal to begin with, or is one kind of being more heavily weighted towards a certain outcome? And so we'll see that the assembly bias can be broken down further into either selection bias or allocation bias. So selection bias is going to be when the subjects are allowed to select the study group that they want to be in. So obviously you can start to see some of the problems here that people who are, say, more educated, more adventuresome, say more health conscious, may want to be on the forefront of medicine and want to try new therapies or some sort of new preventative measure, right? And so the differences there may be partly or entirely due to the difference between subjects rather than just due to the actual intervention you made itself. And so almost any kind of non-random method for allocation of subjects is going to be more prone to producing bias. So again, if you ever see a study that was not randomized, especially like prospective studies, that should be a big red flag to you, right? Especially if people are able to decide, I want to be in the treatment group or I want to be in the placebo group, because that's not going to really be very well. You're not really able to eliminate that sort of bias, and that's going to be the first step of the study. So you're already starting an uphill battle. You can find this, in studies of treatment methods for terminal diseases. So, say for instance, the most severely ill patients are often the ones that are most willing to try a new treatment, and so likely these patients believe that they have little to lose, and so that could be the impetus for them to try something. We see this a lot in certain types of orphan types of diseases, so diseases that are very infrequent, but really have no good treatments for. So say for instance over at Nemours we had one study where we basically had a type of brain tumor that really had no good treatment for it, and this was going to be one of the phase 1 trials for this drug, because unfortunately, it's not really a good way to test those drugs because the actual disease state is so rare. But because that person had really nothing else to try, they were to provide kind of a compassionate use kind of trial, where they were able to give it to the patient to see what kind of differences it made. So again, because of non-selection, a new treatment might be given to patients who are sickest, who have also going to have more poor results. So again, if I give it to more sick people who may be likely to have a bad outcome, that could be tipping my result towards the intervention showing no kind of positive effect. And so it's kind of tough to make that fair comparison between patients who are not as sick, who maybe are more likely to do better. Allocation bias is going to be another form of assembly bias, where basically the investigators are choosing a non-random method of assigning subjects to the study group. So before it was with selection, before the patients kind of determining where they wanted what kind of treatment they wanted. Here it's going to be more the investigator's issue. This can occur if the random method is chosen but is not really being strictly adhered to. So a good example of this would be one study where investigators thought that patients who were being randomly assigned to care either on a teaching or a non-teaching inpatient service, they're trying to determine what patients would do better. And so teaching services are usually ones like residents and students and things like that. And so a lot of the early data was showing that the randomization process tended to be kind of bypassed, particularly at nighttime when there wasn't really a lot of oversight. And this was to ensure that the interesting patients went to the teaching service, right? Because those are more likely to learn things from interesting cases than you are from just kind of run-of-the-mill cases. So because of that, they were having allocation bias, which would lead certain results to do, to either go one way or the other, right? So if you were sending sicker patients or more interesting kind of rare type of disease states to the teaching service, they might have done better or worse depending on the type of care that they were getting there and what type of patients they were seeing. So again, it's really important to make sure you're maintaining the randomization process that requires resisting the pressures of study subjects who maybe want to be placed in the group that will receive a new form of treatment or preventative care. Another good example of this would be we were doing a trial during my fellowship. We're actually looking at a new type of antivenom for pit viper envenomations, things like rattlesnakes and whatnot. And one of the things we had to make sure is that we were only running the trial during business hours, because that was the only time we actually had researchers there or the investigators there to actually operate it, to make sure that patients were being randomized appropriately, making sure they got the right drug assigned to them, to make sure that we weren't having patients ending up in the wrong groups based on that. Okay, so that was one way we were able to diminish the allocation bias, because we made sure we only did it when the investigators were there and not someone who was untrained. Okay. So we can also look at associated problems with validity. And so we know that ethically randomized clinical trials must allow potential study subjects to participate or not. So it has to be voluntary, right? So I can't force anyone to go into a study that is very, very bad ethically, right? Probably, right? Nazis, right? No one likes Nazis. So basically, this introduces an element of self-selection into the participant group before randomization even takes place, right? Because people always have to have the option. So again, because of subsequent randomization, so say you get your patients and then you're going to randomize them after that, the results should be presumed to have internal validity. And so basically what I mean by internal validity is that the results are making sense and the results are statistically sound for just that group of patients, right? So everything is working kind of within that system of those patients that I randomized and I did the intervention on. That has internal validity. Those results are valid for that particular group of patients. And then when I talk about external validity, what do you think that is? Yeah, so I take those results from that small sample size, and who can I generalize that out to within the larger group? And so we'll talk about that, and that can be a problem in just a second. So again, always question yourself, who can these results be generalized to? look at your exclusion inclusion criteria to make sure that the patient you're dealing with, you're trying to make a decision for, is being represented in the literature that you're referencing back to. So a good example of this was in the 1954 polio vaccine trials. So this was a trial where they were basically looking at one intervention group, and they had two control groups. So this is not a frequent study design, but this is what they were using, where basically they had one group that was receiving the actual vaccine, one that was receiving a placebo vaccine, and then a third one who was receiving nothing at all, right? So again, placebo effect was not present there because they already knew that they weren't receiving any sort of drug. So the idea before they went into the study was that it's shown that the rates of disease of polio were being greater in the upper socioeconomic groups than those in the lower socioeconomic groups. So one of the things they were looking at was especially with parents that had more education, patients who were more likely to want to try new experimental drugs, they were being randomized to either receiving the drug or getting the placebo, right? And so those ended up being kind of more patients with higher education, better socioeconomic status, because they wanted to try something new for their children. And you'll see that in the patients with the lower socioeconomic status, what they ended up finding was they didn't want their kids to be considered guinea pigs, and so they said, I don't want my kids to get any of these placebo shots or drug or anything like that, so they're just going to get nothing at all. And so obviously you can see kind of how your groups are being kind of skewed already to where you have more people with high socioeconomic status in the either the treatment or the placebo group, and then people lower socioeconomic status with no treatment.
Why did people in the higher economic status get polio more frequently?
That was the prevailing theory. That's what they thought. That's just what the associations that they were seeing beforehand. So now they're actually testing out to see, is that truly the case or not, right? Okay. Or one investigation to try to determine that. So anyway, so you can see how the groups are kind of unbalanced to begin with. And so the investigators were able to correctly predict that the rate of poliomyelitis would be greater in the control group 1 than in control group 2. And so again, they think this difference is going to be based along the socioeconomic lines. And so during that study period, they actually found that the rate of paralytic poliomyelitis was 0.057% in control group 1, who's that placebo group, and then only 0.035% in group 2. So basically, they were able to find that yes, these patients tended to, in the higher socioeconomic status, there was a difference between those two groups, even though both were receiving no actual drug in that situation, right? So it's one of the things you can see there. And so, other questions about generalizability or that external validity of the results that you get have arisen. There's a large study called the Physicians' Health Study. It was done a long time ago, but basically it was a very costly but very well-performed field trial. They were looking at the use of aspirin to prevent cardiovascular events and then beta-carotene to prevent cancer. And they were looking at approximately 22,000 participants, so a very large study size. But the population they were looking at, the sample they had, was U.S. physicians who were predominantly men aged 40 to 75 years old, who met the exclusion criteria, including never having had heart disease, cancer, GI disease, bleeding tendencies, or allergy to aspirin. So immediately, what do you think about that generalizability? It's pretty good, pretty bad. Going to be very kind of narrow who I can apply this information to based on these results. So they were also looking at early participants had agreed to take part in the study, but after the trial period began, they were actually started excluding patients who had poor compliance. So now, again, they're only looking at patients who have really good compliance. You guys remember what we call it when patients drop out, but you continue to carry that data forward? Yeah, intention to treat, right? So again, if I was censoring all that data because they had poor compliance, I'm further kind of limiting who I can really generalize this information to. So if I were able to find really good results from this, and I could really only generalize it to middle-aged to older physicians who are already in good health to begin with, who had good compliance. Like, that's not your general type of patient you'd be dealing with on a day-to-day basis. It doesn't include women, young men, non-white individuals, people of lower socioeconomic groups. So you can see, even though it was a well-done trial, it's just really not that generalizable to very many people. Now, you could always use this as kind of hypothesis generating and start to apply it to other groups. When you repeat the trial, that could be one thing you could try. But basically, you just have the issue of, who you can take this information and who can you apply it to. And so always keep that in mind. Never just take a study results as verbatim. Make sure you're looking at who the patients were they were actually trying it in. Back to the bias. Back to the bias. All right. So in active clinical study, investigators will focus on detecting and measuring possible causal factors. So looking at things like high-fat diets or smoking, the outcomes of interest. So either disease, health, we kind of discussed this. So they need to ensure that the differences that are observed are not being attributable to measurement bias or recall bias. And other types of measurement bias, or detection bias in this case. So detection bias may be the result of a failure to detect, say, a new case of the disease, a possible causal factor they have not accounted for, or an outcome of interest, right? So you need to be able to detect the things that are occurring in order to count them and measure them. So an example, if you're looking at a study of lung disease, so say you had a case group that consisted of individuals who are receiving care in the pulmonary service of a hospital. So they're getting kind of intensive care within the hospital by this pulmonary service. And then the control group that they were looking at were going to just be individuals in the community. So in this case, the early disease among the controls could be missed because they did not receive as intensive of care or medical evaluation that the people that were hospitalized got, right? Because they weren't getting as many tests or as many visits, exams, so they might have missed the disease that was actually occurring. So it would be a detection bias. And so the true difference between the groups and controls might be less than what the actual apparent outcomes would have been based on that. So maybe detection bias if the two groups of study subjects have a large difference in their rates or the loss to follow-up, right? So again, if patients are dropping out early in the treatment and they are lost to follow-up, they may not be able to detect certain outcomes that are occurring, and so again, that could skew your data, which is why it's important to make sure that you have that intention to treat and you're carrying that data forward just to find whatever differences you can. And so in some clinical trials, subjects who are lost to follow-up may be responding more poorly than the subjects who remain under observation. So they may leave to try other therapies. If they're not getting better, we're going to try something different. And then in other trials, you may see subjects who are lost to follow-up may be the ones who respond the best. Or they say, hey, I'm feeling a lot better, lose interest in the trial, and they go ahead and drop out. So lots of cases is occurring. This is why good follow-up is always really important. This is why you have a lot of research coordinators who are hounding these people all the time to make sure they're keeping up with their visits and whatnot. I know on the pediatric side it can be very difficult to keep up with a lot of these studies, especially some of the ones like our pulmonary service where we're looking at certain multivitamin supplementation, cystic fibrosis patients, and some of those patients, the parents have work schedule issues and they can't bring their kids in for visits and things like that. So that can make the actual measuring and the monitoring of these outcomes be very difficult. So again, measurement bias can occur while collecting baseline data or follow-up data. So imagine the measurement needs to be consistent, it needs to be done equally for all individuals. And so imagine if you're measuring the height of patients with their shoes on, all the heights for one would be too great, right? And then there could be lots of variability between the heights of men's and women's shoes, right? So in case you had a set of these, obviously you might be skewing the data greatly in one direction. I have no idea how they actually take care of those fish. I hope there's probably a lot that don't do it very well. So anyway, and then looking at measuring the weight of patients with their clothes on, obviously all the weights would be too large. Depending if you were in a colder climate, you might have the higher average weight of clothes versus if you're down here in Florida in the summer. So things like that. So making sure that everything is being done equally and being done consistently amongst all patients. Other potential areas of measurement bias, we kind of discussed this before, but if you say had blood pressure values, bias can occur if the investigators at some study sites had cuffs that were measuring incorrectly and causing the measurements to either be higher or lower than what they actually should be. Same thing can occur in medical laboratories where if you have different reagents or tests are not being run consistently, you may be getting different results based on that. So it's important that the values have to be adjusted to make sure that you're looking at one standard normal from each laboratory and that everything is going to be consistent with that. Otherwise, you're introducing new bias into the data. It's also recall bias, which would be basically where individuals who have experienced an adverse effect are going to be much more likely to recall previous risk factors than subjects who never experienced the event at all, right? So if you have a bad experience at a restaurant, you're more likely to go put a 1-star review on Yelp than if you had really good service, right? People have recall bias. So all subjects may forget some information, but the bias is going to result when the members of one study group are more likely to remember things that other members of the other group are not. So this is especially important for retrospective data, if you're doing surveys and things like that. It can be a really big problem in research, especially when you're looking at things like congenital anomalies. So, especially looking at mothers who are giving birth to kids with abnormal infants, tend to think more about the pregnancy and are more likely to remember things like infections, medications they might have been exposed to, and injuries. This may be able to produce a falsely positive association with certain risk factors to the outcome, right? So again, if you're getting more reports of these things like, respiratory infections in the abnormal infant group, you're more likely to have an association there that may be not true. And then there's always random error, also is known as non-differential error. And so this is going to produce findings that are either too high or too low, but it should be in approximate equal amounts, because we know that this is just kind of random error in the data that occurs normally. It's usually less serious than bias that we've introduced based on study design or other things like that. And so again, we know that all data is going to regress back to the mean at some point. So this can decrease the probability of finding a true difference and reduces our statistical power. So in order to counteract this, we can oftentimes either increase our study size, increase the number of population that we had that we're looking at to really find a difference there, or if the effect size is larger, it's going to be more easy to determine the difference between groups. And then we talked about confounding previously. So what is confounding?
Confusing.
Yep, so in the Latin term, it's to pour together. So it's kind of all these different variables that are kind of confounding the data or confusing the data and are affecting it, and things that we need to control for. So looking at things like the percentage of gray hairs on the heads of adults is associated with risk of MI. So probably not really a true causal association there, but we do know that the age is going to be increasing the proportion of gray hairs, and also is going to increase your risk of MI, right? So in this case, if you really wanted to associate, to try to find an association between gray hairs and MI, you would need to control for age, right? So you need to take age out of the equation to make sure that there is a difference. It's truly there. So another good example of this would be women who had high parity were found to have lower rates of breast cancer. So investigators assumed that childbearing was protective against subsequent breast cancer, and that they found, what they actually truly found was that they discovered the best predictor was going to be childbearing at an early age. And so when the age at first delivery was entered into the statistical analyses, the number of offspring at that point no longer predicted the rate of breast cancer. And so again, they were able to look back and say, okay, well, childbearing at a young age may be associated with higher parity anyway. So if you start earlier, you're more likely to have more kids than if you were to get a late start on that. So when they were able to take that into account, the association was made between the parity and breast cancer rate. They found it was actually not causal at all. So again, looking at the young age at first delivery was really the confounder here that was obscuring this this relationship, or causing there to be an association when one really didn't exist. So confounding can be definitely can obscure a true causal relationship. Another example of this would be in the 1970s, a study of predictors for educational success among teenage mothers was conducted, and so they were looking at the analysis of the data and revealed that the age and their grade level was positively associated with their ultimate educational success. And so they said that the older a young mother was, and the higher her grade level in school, the more likely she was to stay in school and graduate. And then also, age was strongly associated with the grade level in school. That the older she was, the more likely she was to be in a higher grade. That seems to make some sense. But then when they were able to look at the effect that age was having within each grade level, what they actually found that age was shown to be negatively associated with educational success. So again, they were then taking the actual grade level that each person was in into account. They were able to look at that confounder, and basically they're saying that the older a teenage mother was for a given grade level, the less successful she was, because then they were able to link that back to things like social difficulties, academic problems that were leading her to be held back, and so it became older in each grade. And so one important aspect of the association, the age and educational success, was obscured by the confounding of the grade level that the person was in. So you take that out of the equation, then all of a sudden you can start to find the associations that are truly there. You can also have synergism that can be affecting this. So this is going to be the interaction of two or more presumably causal variables that the combined effect is going to be greater than the sum of either of the individual effects. So again, looking at something like lung cancer, the risk is going to be greater when a person has been exposed to asbestos and smoking than would be expected if you were just being exposed to either one or the other. So this would be in a case where they can have synergism, and the effects are going to be greater than if you just had one or other risk factor. The next figure is going to show a relationship between the percentage of infants with a low birth weight and the number of adverse factors that were present during a pregnancy. So in this case, low birth weight in the study was defined as 2,500 grams or less. And then the examples of adverse effects could be things like teenage pregnancy, maternal smoking, things like that. And what they found was that for infants with white mothers, the risk was 1.7% had no adverse risk factors. And you see this kind of dose-response relationship here, where the more adverse factors they had, the more likely they were to have a low birth weight. And so then they were looking at this, and similarly for infants of black mothers, you can see in the next figure, those rates were even higher for them. So presumably there's some kind of synergistic factor here, whether it be socioeconomic status or whatever, education, whatever it happens to be, but there's some synergism there with not only the adverse effects, but also ethnicity tend to have some sort of synergism here to lead to a higher rate of low birth weight infants. So the next kind of thing we'll talk about is going to be effect modification or interaction. And so we'll see that sometimes direction or strength of an association between two variables is going to differ depending on the factor or the value of a third variable. And so these are things we need to take into account. So these can be called effect modifiers or interactions, depending on who you're talking to, but they're basically the same term. And so a biological example of an effect modification would be the ways in which the Epstein-Barr virus infection is manifested in different geographical areas. So we know that the virus usually results in infectious mononucleosis in the U.S. However, if you were to look in, say, certain African regions where malaria was more endemic, you would see that Burkitt's lymphoma is going to be a common association there. So now we're having to look at this effect modifier of what malaria is having on these infections. And so to test whether malaria modifies the effects of the Epstein-Barr virus infection, the investigators instituted a malaria suppression program in the African region where Burkitt's lymphoma was usually found, and they were following the number of new cases. So they basically suppressed the malaria there due to fly control or mosquito control or whatever it happened to be, and then looking for new incidents of Burkitt's lymphoma. They found that the incidence decreased, after the malaria was suppressed, but it wasn't, eliminated. So they knew there must be other factors that were seeming to be involved as well. So again, can't take into account every single effect modifier, but you can try to help control for certain ones to see what effects they're going to have on your incidence. So a quantitative example of effect modification were going to be reported rates of hypertension among white women and men surveyed in the U.S. in 1991. And so in this case, they were able to find that men and women, the probability of hypertension were increasing with age, which makes sense, right? And then if they looked at the age group in 30 to 44 years, men were more likely than women to have hypertension. And then in older groups, they actually found the reverse was true, so that as they got older, women tended to have more likely to have hypertension as they got older. So what they're seeing here is that gender did not reverse the trend of increasing rates of hypertension. So no matter what, whether male or female, as you got older, hypertension rates increased, but gender did have an effect modifier on age over time. So statistically, there's an interaction between the age and the gender as predictors of blood pressure. So just goes to show there's lots of factors that are going to be involved here. So, any questions on these particular issues? So it's important to have kind of the definitions down. Remember some of the examples we talked about, how you can kind of differentiate, things like confounders, random error, synergism from one another. All right, clear as mud, I'm sure. Okay, so important reminders about risk factors in disease. So first, one causal factor may increase the risk for several different diseases. So for instance, cigarette smoking, we know is going to be a risk factor for cancer of the lungs, larynx, mouth, esophagus. So it can increase your risk for lots of different outcomes. One disease may have several different risk factors. So again, looking at smoking being the strongest risk factor for chronic obstructive pulmonary disease may only be one of many contributing factors. So certainly other things like alpha-1 antitrypsin deficiency, exposure to occupational hazards like coal dust or silicon may affect this as well. And then, risk of things like MI can be influenced not only by a patient's genes, diet, exercise, and smoking, but also other medical conditions, like high blood pressure, diabetes, things like that. And so for one task of the epidemiologist is to really determine the relative amount that each risk factor contributes to that disease, or for the attributable risk. It's important to try to delineate out which, person has the overall risk, what does each one of those factors play into that. So the possibility and confounding and the effect modification often is going to make the interpretation of these studies difficult, as you know. So there's always, if you look at the discussion in any paper, you're going to be looking at some of the limitations of things that they were not able to account for, or things that they might not have been able to detect. You always know that age is going to be a big confounder because it has such a direct effect on risk of death and many other diseases. So it's important that they make sure they take that into account in most cases. And the advancing age can be an effect modifier, can change the magnitude of the risk of other variables. So as you get older, you may be more prone to something like cigarette smoke having a higher risk than it would be if you were smoking at a younger age. Another example would be, risk of MI increases with age and with increasing levels of cholesterol and blood pressure. And so that we also know that cholesterol levels and blood pressure are going to increase with age. So we can take each of these factors into account to try to figure out what each of them has a role playing in the overall risk for an event occurring in those patients. So we try to control for those things, especially for comparing different samples. We try to control for the differences between them to make sure that we're taking out those confounders and looking just at the specific risk factor and the outcome that we're interested in. We can also do things by making sure we're selecting similar patients to one another. So very frequently you'll see a lot of tests that are done in the results section to show that the groups are very similar. So they'll do something like a t-test for age between groups to show that there's no difference between them, to show that there shouldn't be any confounders for particular variables. So you see that very frequently in a lot of studies. So, in summary, for this section, the epidemiologists are concerned with discovering causes of disease in the environment, nutrition, lifestyle, lots of different factors. It's important to remember the different types of causes, whether it be necessary, whether it be risk factors, things like that, know the differences between those. And then, the research to determine causation is going to be very complicated, particularly because the epidemiologists often do not have the experimental control and have to rely on observational methods. So this is really kind of fraught with problems when we're doing a lot of retrospective studies, because again, these are the easiest ones to do quickly and with a large number of patients, especially with a lot of the registers we talked about. Several criteria have to be established to define a causal relationship. So remember, we need to have the temporal relationship. You need to find that statistical significance between the two, and that you need to be able to rule out other kind of obvious causes. And then showing that these criteria are met is complicated by, we know that a lot of factors are influencing the data, like bias, random error, confounding, and really good study design can help to influence a lot of this and try to remove as much that bias as we can from the data. And so remember the difference between internal validity and external validity. So internal validity it just relates to the actual the findings within that internal patient group, and then how you are able to generalize that out to the larger population is going to be that external validity. Okay, so any questions on that? Been on a big David S. Pumpkins kick lately, so. All right.